Welcome to Discussions with Dr. G. I'm your host, Dr. G, and today we will be exploring the gastrointestinal circus, where, let's be honest, your patient's insides are probably more dramatic than a telenovela. So let's kick things off with puke stoppers, also known as antiemetics. If you've ever been on a med-surg floor, you know ondansetron, or Zofran. It's basically the trailblazer of antiemetics. It is a serotonin antagonist, and it's everywhere. Chemo, post-op, that one toddler who's been vomiting since breakfast. But, and this is a big but, you have to watch out for headaches, constipation, and my personal favorite, QT prolongation. So if your patient's heart is already doing the cha-cha, maybe keep an eye on that EKG. Then there is promethazine, also known as Phenergan. It's a dopamine antagonist, which sounds fancy, but really just means it can knock your patient out and, bonus, give them extrapyramidal symptoms. So if you see a patient suddenly doing the robot, that's not a TikTok trend. It's a side effect. And don't forget metoclopramide, also known as Reglan. It is a prokinetic that can double as an antiemetic. Anyway, it gets things moving, but it can also cause tardive dyskinesia. That's one of those side effects that's not reversible, so you really don't want to mess this up. Dimenhydrinate and scopolamine are anticholinergics used for motion sickness. Don't confuse diphenhydramine with dimenhydrinate. One will help you with mild to moderate allergies, and the other is just going to knock you out so you don't barf while you're in the car and it's moving. For scopolamine, the most common administration method is transdermal patches. So you want to teach your patient to wash and dry the area behind their ear before they apply the patch. They need to apply it 4 hours before they need it and can leave it on for 72 hours before replacing on the opposite side. Now, let's talk about the poop pushers, also known as laxatives. Psyllium, docusate, bisacodyl, magnesium hydroxide, lactulose. Each one has its own personality. Psyllium bulks things up, docusate softens, bisacodyl stimulates, magnesium pulls water in, and lactulose, well, it's the ammonia trapper for those hepatic encephalopathy patients. But here's the thing. Overuse leads to cramping, diarrhea, and if you're really unlucky, dependence. Bowels are not vending machines, people. Don't let your patients use these daily unless it's prescribed. And please, if someone has undiagnosed abdominal pain, don't just throw a laxative at them unless you want to play guess that perforation. Encourage fluids, fiber, and for the love of all things holy, monitor those electrolytes. Oh, and bisacodyl and milk, not friends. The milk destroys the enteric coating, so you definitely want to let your patients know to space those out. Moving right along. Let's get into the plug-ups or antidiarrheals. Loperamide or diphenoxylate atropine are your go-tos. But here's the golden rule. If the diarrhea is infectious, think C. diff or E. coli, do not, and I do repeat this, do not plug it up. That's how you get toxic megacolon, and nobody wants to explain that to an attending. These meds are for non-infectious diarrhea only, and yes, they can cause constipation, along with drowsiness. And with diphenoxylate atropine, you might see some classic anticholinergic effects, dry mouth, blurred vision, urinary retention. So, rule out infection first, and don't let your patients treat these like Skittles. Now, prokinetic agents. Metoclopramide again. This is the multitasker of the GI world. It increases gastric motility, so it's great for delayed gastric emptying, GERD, and yes, nausea. But like I said before, tardive dyskinesia is a real risk, especially with long-term use. And if your patient has a seizure disorder or Parkinson's, no. This is a no. Also, teach your patients to take it 30 minutes before meals. I always forget that part. So, do as I say, not as I do. IBS meds. Let's break it down. For IBS-D, you've got allosterone. Okay. This one is only for women with severe refractory IBS-D. That's IBS diarrhea for those who are interested. And it comes with a black box warning for severe constipation and ischemic colitis. So you need informed consent. And if your patient gets constipated or sees blood, they need to stop the medication immediately. It is not for men, and it is not for anyone with a history of bowel obstruction or irritable bowel disease, which is IBD. On the flip side, for IBS-C, that would be IBS constipation, there is lubiprostone. It increases intestinal fluid, helps with motility, but can cause nausea, diarrhea, and weirdly, shortness of breath right after the first dose. This is usually self-limiting, but you still want to keep an eye out for it. Take it with food and water and monitor for persistent diarrhea. Let's wrap this up with the IBD warriors, probiotics, and those hiatal hernia helpers. For IBD, think ulcerative colitis and Crohn's disease. You've got a whole team: sulfasalazine, prednisone, azathioprine, and infliximab. Sulfasalazine can give you orange urine, rashes, and blood dyscrasias, so monitor your CBCs. Prednisone, infection risk, hyperglycemia, mood swings. Basically, it turns your patient into a gremlin if you're not careful. Azathioprine suppresses bone marrow, and infliximab, being a biologic, can reactivate tuberculosis. So screen for latent TB before you start, and don't even think about giving live vaccines with any kind of immunosuppressant. Your job? Monitor labs, teach infection precaution, and honestly, just keep your head on a swivel. Probiotics. These are your peacekeepers. Lactobacillus acidophilus is the classic. They help restore normal flora, especially after antibiotics. But if your patient is immunocompromised or critically ill, you're going to want to skip it. There is a risk for fungemia or sepsis, and that's not fun to chart. Also, don't give probiotics with antifungals or antibiotics. Wait at least 2 hours in between. And yeah, monitor for gas and bloating, but that's honestly the least of your worries. Finally, hiatal hernia helpers, the anti-acid army. PPIs like omeprazole, H2 blockers like famotidine, and acids, and yes, metoclopramide, yet again. They all reduce acid or promote gastric emptying. But here's a fun memory. I once had a student mix up PPIs and H2 blockers in class, and it turned into a full-on debate about which one is better for acid reduction. Spoiler, they both work, but in different ways. PPIs are the heavy hitters, H2s are the steady eddies. So just remember, with antacids, you're going to watch for renal issues, and with all of them, teach your patients to elevate the head of the bed and avoid eating right before bedtime. And dietary changes: low fat, no caffeine, no alcohol. I know, I'm a buzzkill. All right, guys, that was your crash course in GI meds. Remember, the GI tract is high maintenance, dramatic, and honestly, a little bit of a diva. But with the right meds and a healthy dose of sarcasm, you'll keep your patients out of the bathroom and maybe even out of trouble. Thanks for listening, and don't worry, we'll be back with more Pharm fun next time. Until then, keep calm and monitor those bowel sounds.